So performance metrics, and this will address both nursing facilities and community-based services. So the full continuum, we're very much further along in identifying specific, measurable, collectible, and even in this group, somewhat vetted metrics for the nursing facilities than we are for HCBS, but we will start that conversation as well. So you all have seen some of these metrics before. We've had input from stakeholders in these meetings and in between these work groups, and have a preliminary list of performance metrics for nursing facilities that cover 3 categories: clinical outcome metrics, compliance, and then a 3rd category of person-centered care. And you'll see the list here of metrics, several items. So starting first with the clinical outcome metrics, only for the, I guess, let me ask a question of our team. The metrics apply only to long-stay patients, and that would be for all of these, not just the clinical metrics, or for all of them? Short stay is tougher. Fair enough. Compliance is more of a categorical qualification. In some cases, the metrics that some of them require a duration of data that we wouldn't have for short stay, and of course short stay has a different purpose and trajectory of care. So you'll see here use of physical restraints, incidence of high-risk pressure ulcers, urinary tract infections, residents who were given an antipsychotic, falls resulting in injury, significant preventable weight loss, need for increased assisted daily living support, moderate to severe pain, and avoidable hospital readmissions. And in all but one case, the data source, going to an earlier question, is the MDS itself. And you can see at the far right the sort of originating body, or the collection of metrics that these were taken from, although I will also add several of these were recommended specifically by stakeholders here in Arkansas. But it's a common process to find metrics that are routinely gathered and recommended by national bodies, but then from that global list selected by stakeholders here in Arkansas. So the Nursing Home Quality Forum is the source of most of these. So those are direct measures. The second category is compliance. And here we have really sort of regulatory compliance, federal and state. So for this purpose, we are defining regulatory compliance for purposes of quality metrics as compliance on the first revisit. Now, we will continue to have, just because you fail the quality metric and don't get the added payment amount associated with that, Carol and her team will continue to come and revisit and follow the regulatory compliance process in terms of enforcement through to completion. So what we're doing is piggybacking regulatory compliance, and as a result, we have to decide how many revisits we believe that compliance entails. And here it's not the first, but it's the first revisit. And then minimum staffing continues to be a regulatory requirement at the state level, and we would consider that a performance metric as well.
In our earlier discussions, there was talk about staffing levels, and the federal levels greatly exceed what the state levels are. So how are you going to handle that? There are no federal staffing levels. There's only state staffing levels, but the recommended and what you're judged for on Nursing Home Compare is just a recommendation of the federal government.
Thank you for clarifying that, because you had me going there for a while, and I wasn't aware that there was hard and fast requirements from the federal point of view. So this does not relate to the nursing home or to the Medicare's Compare. It is what we're referring to here is the state minimum staffing requirements.
So you're saying federal up there. So is that going to be deleted in future? Minimum staffing requirements, parenthesis, federal and state.
That's a good question. Any one part of the working group, has there been discussion of using those recommended levels as a metric?
While we certainly hope that staffing levels, aspire to the federal levels, the state level is the only requirement that has been promulgated that are now required.
I believe that. Good, thank you. I think the implication here really we should just focus on the state minimum staffing requirements.
Right. There always has to be adequate staffing, and the adequate is determined not by number, according to the federal regulations, but by what the residents need. And Frank is dying to add something.
The other thing I was going to say is that there is actually some numerical requirements under minimum staffing in nursing homes, and I think it's F352 that requires that there be an RN on duty and that there be also a DON. They're somewhat different in that in one case they require, I think for the DON it's for 40 hours per week, and for the RN it is 35 hours. I may have those mixed up, but there are some numerical minimum requirements in nursing homes as well. I mean, for the federal regs.
So that's a good point of clarification. We'll just confirm, but I believe the intention here really is for this is to look to the state minimum staffing requirements. And so the relevance of this category of compliance is that it's going to be one of the requirements in the medical episodes. We would say it's a requirement sort of to pass. You sort of don't get past go on performance incentives or bonus payments if you're not meeting the minimum requirements, and these compliance would be, by definition, a minimum requirement. And then a third category, as with the clinical outcome measures at a certain level, the third category is person-centered care, and we're still exploring the metrics that would be used, but here are some suggestions. Providers reaching minimum number of elements from a menu of person-centered care metrics, such as dining options, non-intercom announcements. We don't have the full list. I believe we did have a more complete list in the last work group, and I would, if you were not a part of that work group, I would look on our website for the more complete list. Because these are also still survey-based and in development, the suggestion here is that these are based on, for purposes of informational value to start off with. We would measure these. They would not be required for participation or receipt of incentive payments. So just to confirm, as I turn the page here, we would not be thinking of these as used for the points system that would drive performance payments. Let me see if I can get through this description of how this quality methodology would work. So one methodology would be to award points, sort of a points system, and the points would be awarded for each of the metrics added together, and that total would then be used to classify a provider as distinctive, commendable, or acceptable. So the current thinking is that these levels of performance, distinctive, commendable, acceptable, or obviously unacceptable, would be used both at the individual metric stage to determine whether on an individual metric a facility was distinctive or commendable or acceptable, etc., or whether it didn't even meet the minimum threshold, in which case they're sort of out of the game on performance incentives. Points would be awarded on an individual metric basis. Use of physical restraints a provider's, in this case nursing facilities, performance on use of physical restraints would be categorized as distinctive, commendable, or acceptable, and 1, 2, or 3 points awarded, and so on for each of the measures, clinical outcome measures. A total for a facility added together, let's say 15, 20, 25. And then that total placed into a category as well, distinctive, commendable, or acceptable. That final tally is what would ultimately determine the amount of the payment increment, the added payment made to the facility, which could either be a fixed dollar amount or per point or category, or it could be a percentage add-on to the payment. It's 6 one, half dozen the other. A percentage is an amount. Either way. Let me just pause there to make sure that in a second I'm going to talk about how the distinctive and commendable and acceptable levels might be selected. But the basic strategy or the basic components of that, folks tracking. So we'd really use these distinctions of these categories of distinctive, commendable, and acceptable twice in the process. Once for each individual threshold, and that's where the points 1, 2, or 3 would be assigned. Then they'd be added up. Then we would calculate the incentive amounts for the facility as a whole. Part that avoids a facility being able to call itself or being labeled as one or the other of these for just one element.
I have a question with the clinical outcome measures. Are you all going to have a snapshot date that you're going to trigger it off of, such as every quarter? And have you taken into effect that a lot of these QMs have different time spans that they stay on our quality measures?
It becomes very specific to each measure when data for a time frame is available. The principle is we want the metrics for quality as well as for obviously spending, et cetera, to relate to the time period that we're talking about. That usually means there's a lag in order to collect the data and calculate the performance and then make any relevant payment. So and we want to make sure that sometimes that means that that we have to miss a quarter's worth of performance because otherwise we'd have to wait that much longer to resolve it all. But I think that'll come in a later work group where we have specific time frames, very precise data sources, including dates for each of those metrics.
And that'll be put out before it's finalized, right?
Absolutely.
For comment.
One of the purposes of the provider performing periods, the reporting period that we looked at right off the bat, these quality metrics would also be reported to a provider for historic purposes only, not for payment. What if, in other words, is the hypothetic. We'll tell providers, what if this system had been in place last year? How would you have done? What would you have received? And to the extent we know and can tell you, why? And that'll be true for quality as well as any other cost. In this case, what would you have been paid?
Right, and I do understand what you're saying on that. The reason I was asking is back up on your first slides where you're talking about that you're going to start collecting the data, start telling us the reports in January, then this should go into effect potentially this next July. Yeah, when you're looking at the QMs, such as falls with major injury, that can stay on for up to almost a year. So when you're talking about starting something this next July, even though you're just going to give us the data at first to show us where we would be at, if that matrix isn't put in correctly, I can be penalized for something that happened almost a year ago.
So that's helpful. Apparently with that metric, there's a lag.
A long lag. But what I'm trying to say is when I knew something a year ago was a problem and I put a QA plan into place, and we have as a company, as a facility, worked extremely hard on that, but it doesn't show on my QMs yet because I still have that lag time. I want some credit for that.
So we'll bring a proposal to this group, which includes those time frames and if there's a lag in the measurement or if there's not a lag, and what the specific time frames are. And we'll have a chance to vet that and weigh any positives and negatives associated with the methodology at that point. It's good. It's absolutely right, and we deal with this all the time with, as